Okay, so we can start. Esteemed jury, dear participants, ladies and gentlemen, on behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you all for coming and taking part in International Medical Congress of Silesia 2024. My name is Wiktoria Śliwka, and it is my pleasure to coordinate Gynecology and obstetrics session. I would like to cordially welcome the esteemed jury. As president of the jury, Associate Professor Iwona Gabriel, Dr Tomasz Wigarek, Dr Jakub Staniczek. He must be with us online, or no? Okay, maybe late. And Master Róża Motyka. We would like to explain to you the rules of the session. The order of the presentation will be the same as in the abstract book, with one exception. The fourth paper will not be presented today due to personal reasons of the presenter. Dear jury, please keep this in mind when filling out the assessment cards. I will try to remind you about it during the session. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. We will show you the passing of time on the screen of the laptop standing on the desk. Esteemed jury, I would like to kindly remind you that if you are a supervisor of the paper which is presented, you should not assess the work. In that case, please cross off the number on your card. I would like to remind that if the work is presented in English, the discussion also should be run in English. We kindly ask the jury to assess scientific value, way of presenting, discussion on contribution. And when the session ends, we kindly ask to give the cards back to the coordinator. Okay, so I think we can start with the first presentation. Presented by Katowice, association between endometriosis and cocaine and regulated trans speed.
Good morning, everyone. My name is Katowice, and I'm a third-year student from Medical University of Warsaw. Please join me as we dive into the details of my study. So cocaine and amphetamine regulated transcript, CART, is a peptide widely distributed in the central nervous system and peripheral tissues, where it exerts diverse actions. CART has been implied in various physiological processes, including appetite regulation, energy homeostasis, stress response, and addiction. Besides regulating food intake and endocrine functions, it is also proposed to modulate ovarian function and has potential inhibitory effects on follicular development. There are studies regarding CART involvement in gynecological conditions, for example, PCOS, but not specifically endometriosis. So endometriosis is a chronic inflammatory disease. It is characterized by the presence of endometrial-like tissue outside the uterus, commonly found in the pelvic cavity. This condition can cause significant pain, infertility, and other complications. While the underlying pathophysiology of endometriosis remains unclear, recent studies attempt to establish a genetic profile of this disease. So this pilot study aimed to evaluate the level of cocaine and amphetamine-regulated transcript in the blood serum in women with and without endometriosis, as well as assess its possible correlation with this disease. The first objective required laboratory work, and the second required a literature review. So quickly about the methodology. I measured the concentration of CART using an ELISA kit. This pilot study included 7 patients with endometriosis and 10 without, in which endometriosis was excluded by laparoscopy examination. These 10 patients served as the control group. They underwent laparoscopy because of ovarian serum cysts, fallopian tube obstruction, and dermatoid cysts. So here we have results. The mean concentration of CART in the control group was 224.5 nanogram per milliliter, while the endometriosis group, it was 61.4 nanogram per milliliter. Statistical analysis revealed the significant negative correlation between CART levels in patients' serum and the presence of the endometriosis. So in conclusion, this pilot study provides preliminary evidence of the potential negative correlation between CART levels in serum and the presence of endometriosis, which implied the lower CART concentration may be associated with development or progression of endometriosis. Further research with larger sample size and additional investigation into the molecular mechanisms involved are warranted to validate and expand upon these initial findings. Something I will say something about the potential cause of this correlation, because there are not a lot of studies about CART and endometriosis. So there was a study in 2014 in which there was a found correlation between CART and negative correlation between the CART and BMI and the waist circumference. And the same correlation was found between endometriosis and BMI and circumference of waist in a systematic review study. So there is a chance that this leptin correlation with CART may be also the correlation between CART and endometriosis. Thank you for your attention.
Thank you for presenting your work and esteemed jury. Do you have any questions?
Hi, thank you for this presentation. I have 2 questions actually at the beginning. How was the endometriosis assessed? Was it laparoscopic or was it symptom-based?
Yes, it was laparoscopy. The blood was taken from the patients before the operation on endometriosis. So later in the operation room.
So I assume the recruitment went, you see the patient, you consented them, and then everyone has taken the blood, and then you separated the 2 groups, endometriosis versus those that you didn't find endometriosis.
Yes, we had samples from hospital, so I wasn't in the process of assessing endometriosis.
Mm-hmm. And another question is, were there any medications taken by the patients with endometriosis? Because potentially for everything that is in blood, it can be impacted.
Unfortunately, I don't have the data about potential medications taken.
Okay,
by patients.
Thank you so much.
I've got two questions. I know that this kind of study is quite expensive, but I would like to ask, do you plan to increase the number of the group in the future into this kind of study?
Yes, we plan to do the study on a bigger sample because we in our team are interested in the adipokine correlation with its levels and endometriosis, and the CART may be also in this group of factors which can which can induce endometriosis or are potential positive positive impact on its development. So we are planning to increase the sample size because it was just pilot study.
Okay, thank you. And I would like to ask what kind of what is your contribution to in this study?
So I did the laboratory work. Using the ELISA kit, I measured the card concentrations, and then I analyzed these results and create this statistical analysis.
Okay, thank you very much.
Thank you for your presentation. Congratulations. Now it's time to second work. It will be endometriosis path to diagnosis, symptoms, impact on quality of life, presented by Surowaniec Julia.
Ladies and gentlemen, my name is Julia Surowaniec, and I am honored to present you our study from Gynecology and Obstetrics field entitled Endometriosis, Path to Diagnosis, Symptoms, and Impact on Quality of Life. Firstly, I would like to introduce you to the plan of our presentation and explain you why we chose this topic. Over the years, the diagnosis of endometriosis has been a challenge to most of the doctors, and many of these patients were our friends, and that is why we decided to take a look at this serious problem. Patients often heard in the doctor's office, it's just the way you are, or it's normal after reporting symptoms such as painful periods, and that's why we decided to take this topic. Endometriosis is a disease in which tissue similar to the lining of the uterus grows outside the uterus, which leads to the inflammation and scar tissue in the pelvic region, but also elsewhere in the body. It is estimated that 10 to 15% of reproductive aged women suffer from pelvic endometriosis. The aim of our study was to analyze the clinical picture, diagnostic process, and provide a treatment for endometriosis. We surveyed 145 women aged 21 to 49 about their endometriosis diagnosis experience via social media groups, and I can even joke that I am probably on every group, but what is not done for science. And the following data were evaluated: age, symptoms, age of diagnosis, comorbidities, methods used during the diagnostic process, and provided treatment for endometriosis, and also the impact on life. As we can see on the slide, the mean age of patients was about 42, and the mean age of diagnosis was 29. And the most common comorbidities were allergies with 34%, followed by anxiety disorders and depression, and with hypertension at the end. The most common medication were contraceptives with about 50%, followed by antidepressants and other medication, while the average BMI was about 23, and also 32% of patients had BMI above normal. The patient experienced symptoms such as dysmenorrhea with 85%, after that chronic pelvic pain with 65%, but also dyspareunia with 55%. And also less than 36% experienced infertility, menstrual disorder, and afflictions of digestive system during menstruation, such as indigestion or flatulence. And another fact worth mentioning is that also there was presented the lack of symptoms in 6 of patients. The most common diagnostic method was ultrasound examination, but also there was laparoscopy, magnetic resonance imaging, and laboratory parameters measurements such as interleukin-6 or TNF-alpha fluid levels. And what is interesting, the average diagnostic process lasted 4 years and 4 months, and 85% of our study group required consultation of more than one specialist. The most common localization of lesions was ovaries, followed by adenomyosis or extragenitalis with caesarean scar at the end. And when it comes to the treatment, the most common treatment was pharmacological treatment with 38% about, but also other methods such as anti-inflammatory diets were used in our research with 8%. Now, we also measured the impact on patients' life through the acceptance of illness scale, and it turned out that 61% of patients have trouble with adapting to the limitations created by the disease, and also 60% cannot do what they like because of the disease, and also they feel the disease makes them unwanted. Moreover, 45% are more dependent on others than they wish they were, and 28% makes them feel the disease make them defective at times, and also they think that the disease make them feel like a problem for their families. But also 26% of them will never be as self-sufficient as they would like to, and 27% believe that people who spend a lot of time with them are imbalanced because of their disease. What were our conclusions then? Firstly, endometriosis is sometimes misdiagnosed, but advanced diagnostic methods can potentially speed up the diagnostic process. The second, majority of patients experience the symptoms of the disease, but also when endometriosis is left undiagnosed and untreated, it can negatively impact patients' health and well-being. Ladies and gentlemen, thank you for listening to my lecture. Feel free to ask any questions, especially the easy ones. Thank you very much.
Thank you for your presentation, Deirdre.
Hi, I want to congratulate you on a very interesting subject. The endometriosis is still an ongoing question. I have one more like a debate rather than a question, or seeking your thoughts on that. Considering your results on the impact of quality of life of these patients, what would be your advice for our education as doctors or education of medical students regarding this disease, and to speed up the diagnosis? Or do you think we should target high schoolers or parents? How would you approach and try to change what it's left behind so far?
Okay, for surely, we should make sure that the patient is okay. When the patient's telling us that there is a pain, there's chronic pain, we need to listen to them mostly. This is first of all. Second of all, we should consider the treatment when to make their life easier, because endometriosis is really hard and downgrading their lives mostly of the patients because of the chronic pain. So for the medical students or maybe doctors, we should firstly listen to them and not saying that there is the way that that they are, and it's normal. It's chronic pain. It's not always normal. And when the diagnosis is on, we should consider the psychotherapy. As you saw that the really big part of our study group had diagnosis also from the, for example, depression. So there is a group of patients that needs the psychotherapy mostly.
But when we want to diagnose the endometriosis, what kind of methods we should use?
So the golden standard is MRI examination, while when the endometriosis is peritoneal, the recommended examination is a diagnostic laparoscopy.
And I also have to ask, what is your contribution in your study?
So our contribution to the study was resending the service, making presentation, and also acknowledging the people, our friends, about the process and encouraging them to diagnose this endometriosis. But also,
we also evaluated all the data. We divided for the three of us to the whole presentation preparation time, and there was our whole work.
So thank you for presenting your work. Our time is up, so thank you. Congratulations, of course. And now it's time for third work, usefulness of BMI and BAI in assessing glucose and insulin profile among PCOS, presented by Jakub Barszt.
So, good morning, ladies and gentlemen. Today I would like to present this topic about usefulness of BMI and BAI in assessing glucose and insulin profile among polycystic ovarian syndrome in women. So first three little introduction to the topic. So polycystic ovarian syndrome is a condition that affects around 10% of reproductive age women. It affects many parts of human body, but I think these four that I presented are the most important one and are connected to each other. Firstly, it is linked with insulin resistance. It can cause excessive androgen synthesis and excretion. It affects menstrual cycle, and because of that, fertility. And also, it is really frequent with overweight or obesity. So knowing that symptoms, we can see that the higher risk in this condition is really correlated to these symptoms. We have diabetes that are correlated with insulin resistance. We have high blood pressure. We have dyslipidemia, mainly high LDL rate, and many others that are mainly connected to this bad glucose profile. So we used two indices. Firstly is, I think, well known is BMI, body mass index, that is frequently used in many studies. And the second one is body adiposity index. It's less known, but it's really similar. It uses hip circumference instead of weight. In many studies, it is shown that it's complementary to the body mass index. So the aim of the study was to assess the usefulness of these two indices in evaluating abnormalities of glucose and insulin profile in women with this condition. So materials and methods. Firstly, we had 101 women with this condition in the age between 80 and 39. And after some exclusions, we ended up with 49 women. Then we had measured height, hip circumference, and weight, and withdrawn blood. These two things was already done on the Department of Endocrinology by the employees of this department. Measurement was made in the light clothes, and blood was withdrawn in the morning before the breakfast. So also this patient has already been diagnosed with polycystic ovarian syndrome by doctors by 2003 Rotterdam criteria. At least two of these three criteria was met, oligo or lack of ovulation, clinical or biochemical hyperandrogenism, or disturbed image of the ultrasound of ovaries. So these are the two formulas that we used in order to assess BMI and BI. And now we have this criteria that we used in order to make two groups of these patients with normal weight and excess weight. So we have two formulas for the parameters from the blood. We had a homeostatic model assessment for insulin resistant and metabolic score for insulin resistant, but we also from the blood had fasting glucose and insulin, glycate hemoglobin, and we had also oral tolerance glucose test. And to the results. So firstly, about body mass index. So we can see that fasting glucose and insulin was both higher in excess weight, and this correlation was significant. But in the glucose test, only glucose after 16 minutes was significant. All of them was higher in the excess weight, but only this after 16-minute glucose was significant. Also, we can see that HOMAR index was significantly higher in the group of excess weight by BMI, but glycate hemoglobin was not. Also, we had METS-ER, but in this table, we cannot compare it because in METS-ER formula, it is already BMI in this. And about body adiposity index. So we can see similarly to the body mass index that fasting insulin and glucose was significantly higher in excess weight. And similarly, in the oral glucose tolerance test, only glucose after 16 minutes was significantly higher. Also, glycate hemoglobin was not significantly higher, but HOMAR index and the METS-ER that here we can assess because it wasn't in the formula, was significantly higher in excess weight group. So my conclusions are that both of these indices, body mass index and the body adiposity index, are useful in predicting abnormalities in glucose and insulin profile among women with polycystic ovary syndrome. Thank you for your attention. And
thank you for your presentation. I invite the committee to ask questions.
Very nice. I have one question. At the beginning, you showed that 49 patients were excluded. What were the reasons? Because it's actually half of the primarily included number of participants.
Yes, so exclusion criteria, there was a lot of them. Mainly, it was any kind of drugs that could affect glucose, lipids, and there was also diabetes that we needed to exclude. There was any kind of disease that caused excess androgen excretion synthesis, for example, hyperplasia of adrenal glands. Also, there was contraception. There are many more.
Okay, I understand. And my second question, how did you recruit the patients? Were they recruited in the chronology unit, or where did you?
Yeah, there was endocrinology unit where there had been routine diagnostic tests, and we had a base that we created, and we collected all these data, and within that group, we take the patients to this study.
And last question, at least from the statistical point of view, there were differences in HOMA-IR index. Would you think that we should start using it routinely in clinical practice, or it requires further study or larger study?
So I'm not entirely sure. I think HOMA in some kind of, for example, like this, is useful, but I see a lot of studies that think that HOMA is not exactly great index in order to assess insulin resistance. Maybe we should use many other indices, for example, METs and other that are not correlated with insulin exactly. And maybe by using all of them, we could take to some kind of conclusions.
Okay, thank you so much.
Thank you.
There's only one question because two of them was asked. What is your own contribution in this kind of study?
So my contribution was collecting all these data because of blood and measurement was already done on the department. So I collected all the data to the base and also I analyzed already calculated results to this presentation. That's it. Thank you very much.
Thank you. Congratulations, of course. Okay, and as I said at the beginning, the fourth presentation will be not presented today. So dear jury, please move on to value evaluation of work number 5, effects of dietary habits and abdominal obesity and body fat content in women with PCOS, presented by Joanna Kazimierczak. Yes?
Good morning, ladies and gentlemen. I am Joanna Kazimierczak, and today I have the pleasure to tell you about the effects of dietary habits on abdominal obesity and body fat content in women with PCOS. But before we discuss our results, let's remember that polycystic ovary syndrome is a really common hormonal and metabolic disorder affecting women worldwide. And it is highly probable that you know somebody with PCOS because about 10% of women suffer from it. To diagnose PCOS, we rely on Rotterdam criteria, which contains ovulatory dysfunction, hyperandrogenism, and polycystic ovaries detected via ultrasound examination. And to diagnose, we need 2 out of these 3 criteria. PCOS poses several challenges for women, notably impacting fertility due to irregular or absent ovulation. Many with PCOS experience insulin resistance and raising the risk of type 2 diabetes. Cardiovascular issues such as hypertension, high cholesterol, and heart disease are also heightened. Mental health can suffer, often linked with anxiety, depression, and eating disorder. There is a really important piece of information that we should have in mind during this presentation. Obesity commonly occurs with PCOS and can worsen complications of the disorder. Our study aimed to compare the nutritional knowledge of women with PCOS to those without it, while also assessing how their dietary habits affect body fat and abdominal obesity. We distributed our survey to 236 patients, 183 with PCOS and 53 without it, who were admitted to our University Clinic's Gynecological Endocrinology Department in 2022 and 2023. Alongside conducting anthropometric measurements, lab tests, and dietary assessment, and obtained data was analyzed by using Statistica 13. The exclusion criteria were cardiovascular diseases, diabetes, autoimmune diseases, BMI over 40 and BMI below 16, hypolipemic drug intake, diagnosed mental illness, and diagnosed eating disorder. And let's take a look at the characteristic of our group. So the median age of the group was 25. The mean age of the group in the study group was 24.7, and in the control group it was 27.3. Most of the women lived in the city with over 100,000 citizens. The high school and higher level of education prevailed over other levels of education in the group. Furthermore, we checked what phenotype of PCOS women suffer from. There are 4 phenotypes, A, B, C, and D. A contains all of the criteria, B, hyperandrogenism and ovulatory dysfunction, C, hyperandrogenism and polycystic ovaries in ultrasound examination, and D, ovulatory dysfunction and polycystic ovaries in ultrasound examination. And over 50% of patients had the type A, so it was a full-blown PCOS. Now let's take a look at measurements. Women with PCOS had higher weight, BMI, and fat content, waist and hip measurements, waist-hip ratio, body fat to mass ratio, and visceral fat levels compared to those without the PCOS. And as you can see, the p-value in all of those was below 0.05, so there was a correlation. Level of education may have an impact on physical activity, as women with the higher level of education are more likely to take up exercises. We also performed a knowledge test, which was a dedicated part of compound survey, and it consisted of 25 questions about supplementation and nutrition. And the results were frightening. Almost 80% of women with PCOS obtained insufficient test result. At the same time, women without PCOS got better test results. There was a strong correlation between weight and test results, as women with the higher body weight obtained worse test results. Lipid levels were closely tied to body measurements. HDL, the good cholesterol, was lower in women with higher insulin, hip-to-waist ratio, and body fat percentage. Triglycerides, on the other hand, rose with BMI and waist-to-hip ratio, but fell with healthier diet scores. Waist-to-hip ratio was also lower in those with better diet quality, and sex hormone binding globulin levels dropped with higher waist-to-hip ratio and BMI. Summarizing the study, the knowledge about nutrition among women with PCOS is still not sufficient, as it could be the reason why patients obtained worse test results in lab tests and worse anthropometric measurements. Dietary habits had significant influence on abdominal obesity and body fat content in women with PCOS. Understanding that by those women could lead to reduced PCOS-related metabolic complications. Diet plays a crucial role in managing polycystic ovary syndrome because it can directly impact on hormone levels, insulin resistance, and overall health. And here, we would like to encourage gynecologists to start a conversation with patients about changing lifestyle, as the healthy lifestyle could lead to positive long-term effects. Let's remember that hormone therapy does not address the underlying metabolic and hormonal imbalances associated with PCOS. So its effect may be temporary and symptoms may return once treatment is discontinued. And let me finish there. Thank you for your attention and don't hesitate to ask questions. We will try to answer them.
Congratulations, of course, great job. And now it's time to discussion.
Yeah, thank you for this presentation. Very nice. I have one question regarding your conclusions. Would you think we should, as a standard of care, include dietitian in the first visit of patients with PCOS? Because I think usually when we send, okay, maybe you should lose weight or do that or that, it's not very pressing, and you know, there obviously will be patients with the higher education that you've shown that will sort of follow this indication, but other will not, and the consequences of that will apply to everyone, of course. So would you think it would be a good idea to include it, and if so, maybe we should make questionnaires and then send it to dietitian, or what would you think would be the best?
In my opinion, if there is a possibility to see a dietitian by a patient, of course we should suggest it to a patient, but probably they won't make an appointment with the dietitian. So we as the gynecologists should suggest this woman to start a healthy lifestyle, start a diet with reduced processed food, for example, and for example, propose to use applications in the phone, counting calories. And I think it would be a good start for them at the moment when they don't want to see a dietitian. But if it's possible, yes, we should include the dietitian.
Okay, thank you.
I would like to ask, because our lifestyle, our dietary habits is very difficult to change. And can you give us some advice, what we can do to change our bad lifestyle and bad habits?
Mm-hmm. In my opinion, we shouldn't change our lifestyle in a drastic way, because we won't change it. We will get back to our normal habits. So, as I said before, we should, for example, suggest a woman to count calories, to try to eat more vegetables and fruit, should limit the processed food and rich in carbohydrates. So, as I said, it would be a good start for those women.
Okay, and what is your own contribution in this study?
Okay, so I collected data from the body stat in our department, and I also took a part in a presentation, so in making a presentation. So yeah.
Okay, thank you very much for your work, for your time.
Thank you so much.
Okay, and now I would like to invite Patrycja Zembalska to deliver a paper, Factors Influencing the Risk of Cervical Laceration During Vaginal Delivery.
Hey, good morning. My name is Patrycja Zembalska, and I'm pleased to present you, on behalf of myself and the co-author of the work, a presentation about factors influencing the risk of cervical laceration during natural labor. I would like to start my presentation from a few words about table of contents. Firstly, introduction, then material methods, last but not least, results, and conclusion. Here are the most common three questions. So what this cervical laceration actually is, how often does it occur, and what is the aim of our study? Cervical lacerations are tears or injuries of the tissue connecting to the cervix, the vagina. It often occurs during the pushing stage of labor, when a child's head put the pressure on the cervix, lengthen and broaden the birth canal. These injuries can vary in severity and may require medical attention for proper healing. The next question was how often? So, the frequency of cervical laceration during labor depends on various factors, including the method of delivery, the medical personnel experience, the own medical patient history, and other factors of risk. And according to various sources, between 0.2 to 4% of women experience some degree of cervical laceration during natural labor. Aim of study was to evaluate factors influencing the risk of cervical laceration during natural labor. Our study group consists of 63 patients, control group 71, age from 16 to 42 years old, and hospital admission was here next to us in hospital in Ligota up to last 2 years. about the factors which were taken into account, I will tell you a few words later. And about database was analyzed in Statistica software. Okay, so here are some really crucial information. The study group consists of all patients gave birth in the last 2 years who experienced a cervical laceration. The control group was selected randomly by every 20 patients, chronologically from all who gave birth during those 2 years, so from 1,475 patients. Okay. On this slide, we can see the two groups, study group and control group. How you can see, those groups are comparable to each other, and study group is similar to control group in terms like comorbidities, age, BMI, or primipares. Results: cervical laceration during natural labor occur in 63 patients, which constitutes 4.3% of all labors. Okay, this schedule shows the way of pre-induction and induction of labor, and how you could notice follicular, cervidil, and angusta are not statistically significant. However, in a study group, significantly more often occurred cervical laceration during oxytocin induction. Cervical laceration occurred significantly more often in patients induced by oxytocin compared to those non-induced. The slide shows the compare between birthing position and cervical laceration. How you can see, we have checked many of the positions like horizontal, lateral, sitting, standing, and none of them didn't have an influence on cervical laceration. So birth position has no effect on incidence of cervical laceration. How I said before, we took into consideration many factors like water immersion, stage of labor, vacuum extraction, and how you can see, none of them weren't statistically significant. So labor in water immersion, stage of labor, preterm rupture of membranes were not statistically significant. Here are some surprising for us information, because when we were preparing our project and collecting the database, we thought that childbirth wave will have some impact and influence on cervical laceration, but how you can see, firstly, we were wrong, and childbirth wave had no impact on cervical laceration. Also, we did not observe a significant difference in the incidence of cervical laceration between primipares and multipares women. Here you can see a small summary what I have had so far. Regarding to the conclusion, induction of labor with oxytocin significantly increases the risk of cervical laceration during natural labor. Here is our bibliography, and thank you very much for your attention.
Also, a really great job. So it's time to ask questions.
Thank you for a nice presentation, very important topic. Would you think that based on your results, we should add to our counseling that induction with oxytocin may lead to cervical ripening? And if so, let me finish. If so, how would you do that? Because currently, even now, patients are a little bit afraid of oxytocin induction. So, in my opinion, this information may even add more fear to them. So, but maybe the change of the group would change the results? What's your opinion? What's your opinion? Would you think that this is specific, as you mentioned at the beginning? The cervical ripening is also impacted by other factors like medical comorbidities, like experience and all that stuff. So would you think that only oxytocin is still the only factor, or we should include other factors too?
Okay. So we found research papers on PubMed where was the information that cervical cerclage vacuum extension in previous labors, an episode of cervical laceration, stitches on laceration, also lead to cervical laceration. So it's maybe not only the oxytocin induction, so it's first information. And we need more information and in the depth analysis to tell properly for question. But in my point of view, also cervix not sufficiently prepared for labor in Bishop scale also can have an influence. Injuries of cervix, maybe some bacterial infection background also can have, but how I said, we need more information. And on some of the first slides was an information that between 0.2 to 4% of all labors are only or not only the rupture of cervix. So it's not such a huge amount, in my view.
And also, I would like to ask, what is your own contribution to this study?
I was collecting the database. We were checked a lot of labors from a labor book. Also, my friend, which is co-author of the work, she was calculating in Statistica. So she was this Statistica person, and I was collecting database, and we together prepared the presentation.
So I need to interrupt. Our time's up.
Okay,
so thank you very much. Thank you. Okay, now I'd like to ask to present the paper Women's Knowledge of Alternative Methods of Terminating Pregnancy in Their Reproductive Years, presented by Weronika Curyła. Feel free to start.
Good morning, ladies and gentlemen. Today I have the pleasure of presenting to you VBAC and women's knowledge about it. In the last 30 years, so from the 1990s up until today, 2024, there was seen a drastic increase in the cesarean section delivery rate. This was mostly by the dictum, once cesarean, always cesarean. Although this was proven to be wrong, numerous women still stand by this 30 years later. But first, let's start with the basics. What is VBAC? VBAC is an acronym which stands for Vaginal Birth After Cesarean. Once a woman births through a C-section, every subsequent vaginal delivery will be described as VBAC. VBAC has a special name to it because it has some special risks to it. Those risks are uterine dehiscence and uterine rupture. Once a C-section is performed, there is made an incision at the site of the uterus wall, which then is a weaker point prone to damage, which can lead to uterine dehiscence and a more dangerous and drastic form of it, uterine rupture. There are several factors which increase the probability of success in VBAC, and those are prior vaginal birth and spontaneous labor. But on the other hand, there is also a long list of factors which decrease the probability of success in VBAC, all mentioned here above on the slide. VBAC is associated with a decreased maternal morbidity and a decreased risks of further birth complications. So why is it that women still fear VBAC? Is it lack of knowledge about it? Is it because of the risks and the knowledge about the risks that it has? We decided to find out by ourselves in an online survey by asking their opinions. We asked 816 women in their reproductive years, so aged from 18 to 49, in an online survey about their knowledge about VBAC. The online survey contained 38 questions, 31 single-choice closed questions, 3 multiple-choice closed questions, and 4 open-ended choice questions. Then we used the IBM SPSS statistics program for statistical analysis. About what did we ask our study group in the survey? About socioeconomic data, medical history, gynecological history, and most importantly for our study, questions regarding knowledge about VBAC. We divided our study groups by age in 4 subgroups. The biggest one of them, which was more than half of the whole study group, were women who were aged from 25 to 34 years old. Then we asked them if they know what the abbreviation VBAC stands for, and fortunately, only 37.6% replied no, which in our opinion isn't a bad result. Further, we wanted to see if age affects knowledge about VBAC, and as we can see from the diagram, women who replied yes to the question mostly were aged from 25 to 44 years old, and women who mostly replied no to the question were aged from 18 to 24, and some of them also from 45 to 49 years old. The conclusion is that there is, of course, a connection between age and knowledge about VBAC. The result wasn't actually a surprise to us because women who are aged from 25 to 44 years old mostly are already after their first labor or second or third labor, and naturally they're going to be interested in the alternative ways of terminating their pregnancy. Women who are aged from 18 to 24 mostly are not planning on starting their families yet or are before their first ever pregnancy. So naturally, they're not going to think about what is going to happen and how the pregnancy is going to end, the second and third pregnancy. We were also curious about if education has an impact on the fear from VBAC. And we once again divided our study group in 2 subgroups, tertiary education, and the second group was secondary education and women with other education, so mostly primary education. Interestingly, there is no association between education and fear from different ways of giving birth. Both groups showed that they have a similar fear from different ways of giving birth. We were also curious if the number of pregnancy affects the knowledge about VBAC, and as we can see, the vast majority of our study group were women who were at least once pregnant, 68%. They replied to the question mostly yes, and women with no pregnancies replied mostly no to the question. So, as a conclusion, going through at least one pregnancy is associated with better knowledge about VBAC, and there is a need for better education for nulliparous women. As the last conclusion, we thought might be interesting to share was if the number of labors affected the possible decision for undergoing VBAC. And as we can see from the diagram, the 2 subgroups, so women who were once pregnant or never pregnant before, and the second subgroup, so women who were at least 2 times pregnant, agreed that they would undergo VBAC, although it is worth pointing out that women who were at least 2 times pregnant were more eager to try out VBAC. We created, as a summary, a take-home message. And first of all, there is a lack of education of VBAC, although it is likely that it has gotten better over the past years. Women are more eager to try VBAC if it is possible. We should encourage more of the medical staff to talk through the procedure because the better the education of patients about VBAC, the better will be their safety, and we can hope for the increase of popularity of VBAC. Thank you very much for your attention. Now feel free to ask any questions. I would like to invite my colleagues to the stage, please. Thank you.
Again, congratulations for your great job. And now it's time to ask questions, maybe.
Hi again, very important topic as you shown a very little knowledge in general. I have only a comment. If you decide to publish it or extend and publish, then I would change terminating pregnancy.
We thought about this already. Yes, thank you.
Towards more
Ending the
politically
pregnancy.
correct
Yeah.
conducting or the end of pregnancy or whatever it is, yeah, as you think. And I also have a question. How did you approach the groups? What kind of social media groups these were? Were they groups related to your department that follow your department website, or were it general audience?
It was actually mixed. We used our social media, mostly Facebook, Instagram, but also some groups, midwife groups, because our friend here is a midwife. She's actively working as a midwife. So mostly mixed, yeah.
Okay, thank you.
Thank you.
And I would like to ask one question, because this kind of patient is quite common. Women after the cesarean section is quite common in our population, and I would like to ask who plays the biggest role for a patient to knowledge how the labor should go on.
So in our opinion, the biggest, the most important source should be medical staff. But actually, from our questionnaire, the answer was that the internet has the greatest impact on patients. So we encourage medical staff to post on their Instagrams, social media, Facebooks, maybe creating blogs, posting anything related to VBEC and the knowledge.
Okay, and the last question: what is your contribution to this study?
So I was responsible for the presentation for the speech today, obviously, and also we created, the three of us, the presentation. The data was every single one of us sent the data to our friends, to the groups on Facebook, and we also equally made the questions for the questionnaire.
And we also dropped the idea of this topic and also created a questionnaire that was performed.
So thank you very much. Nice job. Thank you. And yes. Okay, and now it's time for 8th presentation, today's session, the relationship between postpartum women's quality of life and quality of sexual life, presented by Natalia Węglosz. Sorry, Natalia Węglosz.
Szanowna Komisjo, drodzy słuchacze, jestem niezmiernie zaszczycona możliwością podzielenia się z Państwem wynikami badań, które przeprowadziłyśmy w aspekcie bardzo ważnego, ale i też wydaje mi się, że często pomijanego tematu, jakim jest korelacja między jakością życia seksualnego kobiet po porodzie, a jakością życia ogólnego. Zaprezentuję Państwu na podstawie prezentacji wyniki badań, w których udział wzięłam ja, Natalia, Marta Urbaniak oraz Julia Sindera. Jesteśmy studentkami 4. roku fizjoterapii stacjonarnej Katedry Fizjoterapii Wydziału Nauk o Zdrowiu Śląskiego Uniwersytetu Medycznego w Katowicach oraz członkiniami Koła Naukowego Metod Specjalnych i Kinezoterapii pod patronatem doktor habilitowanej nauk medycznych o zdrowiu Magdaleny Dąbrowskiej-Galas oraz doktor nauk medycznych Magdaleny Rutkowskiej. Przejdźmy zatem do prezentacji. Proces porodu jest to niewątpliwie bardzo wyjątkowe wydarzenie w życiu każdej kobiety, które może stanowić pewnym rodzaju wyzwanie, które może tak naprawdę zostawić trwały ślad w psychice, samopoczuciu, czy też na przykład w sferze intymnej. Poprawa jakości życia seksualnego ma niewątpliwie bardzo ważne i fundamentalne znaczenie dla ich ogólnej jakości życia. Przede wszystkim przyczyniając się tym samym do optymalizacji zdrowia, do zwiększenia poczucia własnej wartości, do zwiększenia relacji, chociażby nawet tych partnerskich, czy też na przykład do tak naprawdę zwiększenia dobrostanu emocjonalnego. Celem naszych badań była ocena jakości życia seksualnego kobiet po porodzie i jakości życia ogólnego, gdzie w głównej mierze chciałyśmy się skupić tutaj na korelacji między jakością życia seksualnego a jakością życia ogólnego kobiet po porodzie. W naszym badaniu wzięły udział 74 kobiety w wieku od 18 do 55 roku życia, gdzie kryterium włączenia były kobiety, które zgodziły się na przeprowadzenie tego badania, kobiety po porodzie oraz kobiety powyżej 15 roku życia. Natomiast kryterium wyłączenia były to kobiety, które ten kwestionariusz nieprawidłowo wypełniły. Dodatkowo warto tutaj wspomnieć, że nasze badanie opierało się o naszym autorskim kwestionariuszu FSFI oraz kwestionariuszu WHO Cool of Life, gdzie te kwestionariusze FSFI oraz WHO Cool of Life są to kwestionariusze, które są wystandaryzowane, walidowane oraz międzynarodowe, dzięki czemu w prezentowanej prezentacji będziemy mogły w stanie odnieść się do innych wyników badań. Jeżeli chodzi o kwestionariusz FSFI, on składa się głównie z 6 domen. Jest to domena pożądania, podniecenia, lubrykacji, orgazmu, zadowolenia seksualnego i dolegliwości bólowych związanych z tą seksualnością, gdzie punktem tak naprawdę odniesienia będzie wynik 26 punktów, ponieważ od niego będziemy tak naprawdę decydowali, czy te dysfunkcje są, czy tych dysfunkcji nie ma. No i wynik powyżej 26 punktów będzie świadczył o tym, że tych dysfunkcji seksualnych nie ma, a poniżej 26 punktów to będzie świadczyć o tym, że te dysfunkcje będą się tutaj pojawiały. Natomiast jeżeli chodzi o kwestionariusz WHO Cool of Life, ten kwestionariusz składa się głównie z domen socjalnej, środowiskowej, psychologicznej i społecznej, gdzie możemy tutaj w każdej z domen zdobyć maksymalnie 20 punktów. I tak naprawdę im wyższa jakość tego, im więcej tych punktów, to wtedy będziemy mówili o tym, że jakość życia jest zdecydowanie wyższa. Jeżeli chodzi o wyniki, to około 60% kobiet tych dysfunkcji seksualnych nie miało. Możemy zauważyć, że najlepsza jakość życia seksualnego była w domenie zadowolenia seksualnego, natomiast najgorsza w pożądaniu. Średnia z tych badanych wynosiła 25,81%, co w konsekwencji możemy tutaj poświadczać, że jest to obecność dysfunkcji seksualnych. Natomiast w kwestionariuszu WHO Cool of Life tutaj możemy zobaczyć, że najlepsza jakość życia ogólnego była w domenie środowiskowej, natomiast najgorsza tutaj w relacjach społecznych. Średnia z tych badanych wynosiła 82% około. I tutaj warto również wspomnieć, że w naszym tutaj badaniu głównie chciałyśmy się skupić, żeby grupą kontrolną versus grupą badaną były kobiety, które tych dysfunkcji seksualnych nie miały oraz te dysfunkcje seksualne miały. Korelacja Spearmana między jakością życia seksualnego a wieku nie wykazała istotności statystycznej. Korelacja ta jest nieznacznie ujemna, że wraz z wiekiem jakość tego życia seksualnego jest gorsza. Natomiast w korelacji Spearmana WHO Cool of Life z wiekiem ta korelacja jest dodatnia, wykazała ona istotność statystyczną, co poświadcza o tym, że wraz z wiekiem jakość tego życia ogólnego jest lepsza. Analizując generalnie wszystkie domeny z kwestionariusza WHO Cool of Life, możemy tutaj zobaczyć dwie istotnie statystycznie korelacje. Korelacje te to jest domena środowiskowa z wiekiem oraz domena relacji społecznych z wiekiem i obie te korelacje są dodatnie. Przeanalizowano wszystkie domeny jakości życia względem dysfunkcji seksualnych lub ich braku i tylko w tych 2 domenach wykazano istotność statystyczną. U kobiet z brakiem dysfunkcji odnotowano wyższą jakość życia w tych domenach. Jeżeli chodzi o wnioski, to jakość życia kobiet po porodzie jest zadowalająca, z wyjątkiem oczywiście strefy relacji społecznych, gdzie jakość życia jest najniższa. Znaczący procent kobiet po porodzie zgłasza problemy z dysfunkcjami seksualnymi, szczególnie w aspekcie satysfakcji seksualnej. Kobiety, które nie doświadczają dysfunkcji seksualnych, cieszą się lepszą jakością życia społecznego oraz ogólnego. Chciałabym bardzo serdecznie podziękować za uwagę oraz zaprosić tutaj moje współautorki i zapytać się Państwa, czy mają Państwo jakieś pytania.
Teraz nie wiem, czy mówić po polsku, czy po angielsku. Dziękujemy bardzo za Waszą prezentację. Proszę o pytania.
Tak, dziękuję za ciekawą prezentację. Ja mam takie w sumie 2 pytania. Pierwsze, po jakim czasie od porodu były zbierane te kwestionariusze i w jaki sposób Państwo pozyskiwali jakby uczestników badania?
To tutaj, jeżeli chodzi o pozyskiwanie tych uczestników, to rozsyłałyśmy ankiety. Były to kwestionariusze online po różnych grupkach i jeżeli chodzi o kwestię kwestionariusza FSFI, to ten kwestionariusz tam się opierał od 4 tygodni, a grupę badaną miałyśmy kobiety, które od 4 lat mniej więcej po porodzie były.
Mhm. Czyli ten okres od porodu był dosyć długi, a nadal ten brak pożądania się utrzymywał, tak?
Zgadza się.
Mhm. Dobrze, dziękuję.
Dziękuję bardzo.
Ja jeszcze chciałem tylko spytać, bo tam nie zauważyłem, czy tam było też różnicowanie na liczby pacjentek, które były po porodzie siłami natury, a te, które były po cięciu cesarskim, czy one po prostu były klasyfikowane jako pacjentki łącznie po prostu po porodzie?
Były one klasyfikowane jako łącznie kobiety po porodzie. Generalnie nie miałyśmy tutaj zróżnicowania na kobiety, które rodziły siłami natury oraz które cięciem cesarskim miały poród.
Okej. Chciałem jeszcze spytać, jaki wkład własny Panie miały w prezentowaną pracę?
Jeżeli chodzi o cały wkład własny, no to począwszy od stworzenia tego autorskiego naszego kwestionariusza, potem rozsyłanie tak naprawdę tych ankiet, przeprowadzenie badania, stworzenie abstraktu, stworzenie prezentacji i tak naprawdę to jeszcze analiza statystyczna, którą razem z naszą opiekunką starałyśmy się tutaj ładnie, dobrze pokazać i zaprezentować.
Gratuluję wystąpienia. Mam jeszcze pytanie takie uzupełniające. Nie brały Panie pod uwagę ewentualnych obrażeń krocza, obrażeń na miednicy podczas porodu?
Tutaj generalnie w naszym badaniu chciałyśmy się tutaj właśnie głównie skupić faktycznie nad tą całą jakością życia, nie uwzględniając faktycznie tych dysfunkcji, z tego względu, że była to nasza ankieta taka pilotażowa i dopiero później, jeżeli tutaj już jakieś wyniki naszego badania wyszły, to chciałyśmy dopiero później, mając już jakiś punkt odniesienia i punkt wyjścia.
Mają to Panie w planach.
Mamy w planach,
Dziękuję.
tak jest. Dziękujemy bardzo.
Dziękuję Wam bardzo. Gratulacje. Okay, now I need to back to English. So now it's time to ninth presentation of today's session, knowledge about cervical cancer and preventive screening among women will be presented by Julia Mzyk. Good morning, ladies and gentlemen, dear Commission. My name is Julia Mzyk, and in honor of our team, I would like to present to you our work. Knowledge about cervical cancer and preventive screening among women. Our presentation consists of introduction, materials and methods, results, and conclusions. Cervical cancer is the most common cancer of the reproductive system and 4th most common cancer among women worldwide. In developed countries, it's very rare due to established screening tests and vaccinations over the years. The most vulnerable age group is postmenopausal women, typically aged 55 to 59 years old. The primary risk factor is infection with human papillomavirus. Nearly 100% of cervical cancers are linked to this pathogen. Additionally, women who initiate sexual activities early, have multiple sexual partners, and have had multiple births are more likely to develop the disease. Early stages of this cancer often show no symptoms, while late stages manifest as abnormal bleeding and discharge. HPV, or human papillomavirus, is primarily associated with cervical cancer. It is important to also remember that it's also an etiological factor in other cancers, such as vaginal cancer, anal, vulvar, penile cancer, and even cancers of head and neck, including the oropharynx, base of the tongue, and tonsils. Additionally, it can cause genital warts and recurrent laryngeal papillomatosis. The aim of our study was to assess women's knowledge about cervical cancer, its prevention, and about human papillomavirus. In our study, we used an online survey, which consisted of 3 parts: socioeconomic data, gynecological interview, and 14 original questions about cervical cancer, HPV. We gathered 119 answers. The results were following. Among our respondents, the most common age group was 18 to 25 years old, with the majority of education at the secondary level, and most of the respondents residing in cities below 100,000 citizens. Respondents answered questions about HPV and vaccination. For instance, 97% of the respondents think that education about preventing cervical cancer should be provided in schools. 71% of the participants know that sexual activities are associated with HPV infection, and sadly, only 23% plan to get vaccinated about HPV in the future. According to gynecological interview, over 77% of respondents attend gynecological checkups at least once a year, and over 22% once every 3 years, 5 years, or even less frequently. Unfortunately, 12.6% of the respondents have never undergone cytological testing. Our study has shown that there is a correlation between the frequency of routine gynecological exams and knowledge about cervical cancer. Among our respondents, 109 individuals correctly answered the question regarding the recommended frequency of cervical cytology screenings, and a remarkable 100 of them followed this recommendation. Regarding HPV vaccinations, over 85% believe that girls should be vaccinated, while over 79% also believe that boys should be vaccinated too. However, 58% of the respondents do not intend to get vaccinated themselves, while over 22% have already been vaccinated. A significant majority of people can recognize the link between HPV and cervical cancer. However, less than half of the respondents know that the virus can also be responsible for other diseases, such as vaginal, anal, penile cancers. Results in its analysis revealed that women who are already vaccinated or plan to do so in the future have higher knowledge about HPV and cervical cancer. The study also showed that younger women achieved better results in the part of the survey concerning HPV and cervical cancer. As sources of knowledge, responders mostly cited the internet, television, and social media, and their gynecologist. Moving to the conclusions. Educating women about HPV, promoting vaccinations, and promoting regular cytological screenings are key to preventing many cases of the cervical cancer. Education should be conducted using social media and gynecologists because these sources play the most important role among our responders. Thank you so much for your attention. If you have any questions, please feel free to ask them. Okay, thank you for presentation of your work, of your study, and our committee. Do you have any questions? Okay.
Very nice and important topic. Would you think that based on your answers, do we still need to change our mentality as doctors first? Because I don't see family doctors recommending HPV vaccinations for youngs, even now when it's reimbursed, which we hoped for, because obviously we're not the first line as gynecologists, somebody else is, pediatricians, family doctors. So would you think that publishing your results would be helpful for all of us to change our mentality? And if so, would you enlarge the study group? Because somebody might say that, you know, around 100, it's not enough for a survey. I would target for like 1,000 probably.
Yes, I think it's extremely important to maybe educate pediatricians and also family doctors to educate our patients, because as we learned, HPV can be prevented, like 100% can be prevented. And with prevention of HPV infection, we can prevent cervical cancers. So I think mostly pediatricians should educate parents to vaccinate their children, and also family doctors should do the same. And I think publishing our study will and also enlargement of our study group will do that, and that is the aim for the future.
And I would like to add that it was shown that the most important source of knowledge is internet, and gynecologists show. So maybe it's a hint for our government and universities and doctors to be more in the internet and in social media to like spread the knowledge in the younger women, which is more important, I guess. And yeah, that's it.
And do you know how the medical screening of cervical cancer look like in Poland?
Yes, so the screening, there is a discrepancy here because the recommendations and the funding of the cytological screening don't really go with each other, because the reimbursement are only once every 3 years, and the recommendations say that we need to do the cytological screening once every year. So there is a discrepancy here.
Thank you for your answer. I need to interrupt because we're out of the time. So thank you for your presentation. Now it's time to 10th work, but I'm not sure that the presenter is with us. Łukasz Karoń, are you with us online? Work number 10, Impact of Fertility Knowledge. Yes. Okay, so we come back at the end of the session. So next, Małgorzata Toroń. Okay, she will present it as her work about analysis of histopathology results of the endometrium in breast cancer patient treated with tamoxifen.
Ladies and gentlemen, from year to year, breast cancer remains one of the most cancer-related causes of death among women worldwide. According to World Health Organization from 2022, over 2 million of women were diagnosed with breast cancer, and 1 to 20 women will be diagnosed with breast cancer at some point of their lives. So that's why we, as medical students, we would like to, and future gynecologists, we would like to treat cancer without any consideration and without any cost, other and sometimes not taking into the consideration its side effects. And that's how Paracelsus famously said, "The dose makes the poison." And that's why one of the most frequently used substance that is used in the therapy with the breast cancer is tamoxifen. Tamoxifen is a selective estrogen modulator, and it is chemically similar to the estrogen. That's why it works like estrogen, inhibiting the estrogen that is released from the breast tissue. But as every substance, tamoxifen causes a lot of side effects, and one of these side effects is proliferative changes in endometrium. As we can see on this presentation, the thickening of endometrium, and here is the ultrasound from the patient that was taking tamoxifen therapy for 5 years. Approaches into the tamoxifen changed through the time. In 1994, the publications were mostly highlighted the risk of endometrial carcinoma, but through the time it has changed a lot. And nowadays, in 2022, there is the risk of endometrial polyps, hyperplasia, and another findings. Therefore, the question arises, what's true? Should we be still aware and afraid of endometrial carcinoma in the therapy of breast cancer with patients undergoing tamoxifen therapy? That's why our study aims to compare histopathological results of the patients that were undergoing tamoxifen therapy and were treated with tamoxifen. We compared 2 study groups. One of them were asymptomatic patients that were referred to hysteroscopy due to the ultrasound findings, and second group were the bleeding patient. For example, the postmenopausal bleeding or heavy irregular bleeding patient. Our study included 102 patients. All of them were hospitalized from 2013 to 2024. They had in the history the breast cancer and were undergoing tamoxifen therapy. And for statistical analysis, the chi-square test was performed. The first group included 51% of the group, and the second group, luckily, also 49% of the group. During our study, we were supposed to exclude 11 patients from group number 1 and 6 patients from group number 2 because the histopathological material during the hysteroscopy could not be obtained. Here you can see the results from group number 1. And as it follows, the first place were the endometrial polyps with 40% of results. Secondly, atypical hyperplasia, 15% of results, and endometrial carcinoma was at the third place with only 6% of our results. Then we also have another findings such as hyperplasia without atypia and others such as atrophic endometrium, submucosal fibroids, and proliferative endometrium. What about results in group number 2? They were similar. Again, at the first place were endometrial polyps with 32%, then atypical hyperplasia 14%, and endometrial carcinoma only 8% of the women in our group. And here is also really crucial to highlight that the proliferative endometrium was also the high amount of our results, and it was nearly 20% of the women. What are the conclusions from our work? Firstly, there were no statistically significant difference in occurrence of endometrial carcinoma and atypical endometrial hyperplasia between the 2 study groups. Secondly, the endometrial polyps were the most frequently observed histopathological results in both of group 1 and group 2. And thirdly, notably, proliferative endometrium was more frequently observed in the group number 2, which is normal for the patient, for the postmenopausal patient with bleeding. Furthermore, we can see that bleeding is not really crucial. And even if the patient is not bleeding, the gynecological follow-up ultrasound examination is also really crucial in those patients, even if they are not bleeding and they are undergoing tamoxifen therapy. What's next in our study? Firstly, we would like to expand our patient group. There's lack of Polish publication into the Polish population of women. That's why we would like to explore the problem. Secondly, we would like to evaluate our results and reanalyze them with another data, such as, for example, BMI, which we could see in our preliminary report that was also increased. Thank you really much for your attention. Here are my references and our team. Thank you.
Thank you for presenting your work. Esteemed jury, do you have any questions? Do you have a presenter?
Hi, thank you for an interesting presentation. I have a question. In your group 1, one in 5 women, they did not have a sample that was diagnostic. Can you comment on that?
Yes.
I think it's on the next slide if you move up.
Yes. So firstly, as I said before, it was the problem with obtaining the material during the hysteroscopy. That's why, like in some women, we have the problem during the hysteroscopy with obtaining the material.
So do you have any ideas, because this you will need for power calculation furthermore.
Yes, true.
So let's say you want to target for 200 patients in one group, then probably you would have to add another 25 patients because they will be dropped out during the study. So this is my comment, and it's really important to educate people that that there are no statistical differences between the groups because obviously patients are afraid of using tamoxifen or other receptors that could target endometrial lining. So that's more or less that. Thank you.
Yes, that's true. I'm aware that this is in some point the limitation of the study. That's why we would like to expand this group of patients and also reanalyze these results, take into the consideration another findings and explore this topic.
Thank you.
And what is your contribution in this study?
Mainly everything, I would say. Firstly, we review all the papers. Then we had this idea that something is like here to achieve, because from one point we have the endometrial carcinoma, in another publications we have endometrial polyps. Then we prepared the database. We could see that in the hospital there were women that were undergoing tamoxifen therapy. Then we prepared all the statistical or the database with statistics and the presentation, which I'm responsible for today.
Okay, so thank you very much.
Thank you.
Thank you. Congratulations again. And now I would like to invite Iga Szymańska to deliver a paper, Metabolic Disorders Among Underweight Women with Functional Amenorrhea.
Ladies and gentlemen, my name is Iga Szymańska, and I am pleased to present to you the results of our study investigating metabolic profiles of women with functional hypothalamic amenorrhea.
Before I move on to the results of our study, I would like to present the topic of functional hypothalamic amenorrhea. It's one of the most common causes of secondary amenorrhea, and by definition, it excludes organic causes. In women with functional hypothalamic amenorrhea, we have the disruption of pulsatile-gonadotropin-releasing hormone secretion, which leads to the decreased amplitude or frequency of gonadotropins. And as a result, there is lack of ovulation, lack of follicular development, and low estradiol levels. The cause of hypothalamic amenorrhea is stress. It can be either mental or physical stress. Physical stress includes excessive exercise and dieting. What is interesting is that not solely exercise can cause amenorrhea, but it needs to be followed by not sufficient amount of food intake. What other studies have found is that in women with functional hypothalamic amenorrhea, there is lower concentration of factors inhibiting appetite, such as leptin, and a higher concentration of factors stimulating appetite, such as, for example, ghrelin. Other studies have also found the higher prevalence of lipid disorders among women with amenorrhea. And what is more, they also found the higher prevalence of cardiovascular diseases. Since the research on this topic is still scarce, we decided to conduct a study comparing women with functional hypothalamic amenorrhea with women with normal menstrual patterns. We used hospital database of over 300 women, and we divided them into a study and control group. We analyzed such factors as BMI, thyroid-stimulating hormone prolactin and morning cortisol concentrations, fasting insulin and fasting glucose concentrations, and lipid panel. We divided our group into study group, which were women with functional hypothalamic amenorrhea, and the control group included women with normal menstrual patterns. As you can see, most of the women in our study had healthy weight according to BMI. What we found out is that women with functional hypothalamic amenorrhea had statistically significant higher total and LDL cholesterol levels compared to the control group. There wasn't statistically significant difference in HDL cholesterol levels between study and control group. But what is interesting, in women with functional hypothalamic amenorrhea, those with normal weight according to BMI had statistically significant higher HDL cholesterol levels. There wasn't statistically significant difference between triglycerides concentration between study and control group, but women with functional hypothalamic amenorrhea had statistically significant higher morning cortisol levels. Women with amenorrhea had also lower prolactin levels, and the difference was statistically significant, but there wasn't statistically significant difference in thyroid-stimulating hormone concentration. We used fasting insulin and fasting glucose to assess insulin resistance, and as you can see, most of the women in our study had insulin resistance. But what is interesting is that the lower prevalence of insulin resistance was noted in those women with functional hypothalamic amenorrhea. Moving to the conclusion, as you saw in our study, women with functional hypothalamic amenorrhea had higher LDL and total cholesterol levels. Patients with functional hypothalamic amenorrhea and healthy weight had higher HDL cholesterol levels. The metabolic disorders concerned lipid panel, but the insulin resistance prevalence wasn't higher in this group. The morning cortisol, as you saw, was statistically higher in women with functional hypothalamic amenorrhea, which is a confirmation of chronic stress. And prolactin was decreased, which is interesting because, as we know, prolactin is released in the states of stress. But here we think that it's because of the inhibition of anterior lobe of the pituitary. There's still room for this research on this topic, but for this day, we would like to encourage gynecologists and endocrinologists to pay attention in those patients with amenorrhea in the aspect of lipid disorders. Thank you for attention, and feel free to ask any questions.
Thank you. Nice work. Now it's time to discuss.
Very nice work. I have a question. You've seen on the slide with methods that more than 300 patients were included for during 5 years, as I assume. So to make this diagnosis of functional amenorrhea, what would be the steps?
Oh, it's a long way because we need to exclude organic causes. So for the start, we need to assess luteinizing hormone, follicular stimulating hormone concentrations. We need to assess thyroid concentration. We need to make like this whole panel of hormonal factors, estradiol, of course, gynecological examination, body composition examination. We need to assess if there is hyperprolactinemia, and if yes, and if there are any symptoms such as vision disturbances, we need to make MRI of the pituitary. So it's a long way. We need to exclude, for example, also Cushing syndrome, like every endocrinopathy that can cause amenorrhea. We just need to exclude.
So do you have a knowledge what's the percentage of patients with this disease in Polish population or European population?
I don't know the exact data, but I know that it's one of the third causes of secondary amenorrhea. So it's, I would say, quite common, because when we see a patient who has secondary amenorrhea, we need to think about this reason, because it's 1/3 of those patients.
Thank you.
And I would like to also ask, what is your own contribution to this study?
So I gathered the database, I analyzed statistically, and I performed the presentation.
We have time, so maybe our online committee wants to ask any questions? No. Okay, so thank you for your work. Thank you. And now it's maybe the last presentation, today's session, Impact of Pelvic Organ Prolapse on Sexual Function, Depending on Women's Lifestyle, presented by Laura Więcko.
Good morning, ladies and gentlemen. My name is Laura Więcko, and today I would like to present to you the results of our small research about pelvic organ prolapse and its impact on sexual function depending on women's lifestyle. So at the beginning, you need to know what pelvic organ prolapse, POP, means. It is a situation when pelvic organs drop from their position. And when we say pelvic organs, we mean uterus, bladder, urethra, vagina, and rectum. And the second important for us term is pelvic floor disorders, PFD. It is a group of conditions related to the abnormal anatomy or functioning of the pelvic organs. Let's go over the main causes of these changes, which are pregnancy and labor, menopause, chronic diseases, and physical activity, especially heavy lifting. Okay, most noticeable symptoms include feeling fullness or aching in the vagina, urinary and bowel disorders, as well as sexual disorders. We have 6 major types of pelvic organ prolapse: bladder prolapse, cystocele; rectal prolapse, rectocele; small bowel prolapse, enterocele; urethral prolapse, uterine prolapse, vaginal vault prolapse. And at the bottom of the slide, you can see the main elements of pelvic floor disorders: fecal and urinary incontinence, the most valid for us, pelvic organ prolapse, and also pelvic pain. The primary aim of this study was to demonstrate the impact of pelvic organ prolapse on women's sexual function and the relationship between lifestyle risk factors and pelvic floor dysfunction symptoms. The study was based on survey only for a woman. We collected responses from 205 women, and they answered 61 questions, where the last 14 were about their sexual life. We mainly asked women about their daily lifestyle, whether they have symptoms of PFD, and how they can assess their sexual satisfaction. Most of women with PFD age 21 to 30, and the second largest group were women aged between 31 and 40. We surveyed 144 women with PFD, including 24 women with POP. Now let's move on to the next part, childbirth. So 60% of women with PFD have given birth, and the most of them have given birth twice. The second chart tells us about the recent deliveries method, and the majority of women have given birth naturally, and the rest of them had a C-section. On the last chart, you can see amount of childbirths in a group of women with PFD whose the last delivery was natural. In this case, more than a half of women have given birth twice. Okay, what is surprising for us, 60% of women with PFD have a normal BMI. What is less surprising, almost 80% of women are physically active. The most relevant slide of our presentation is about the changes in sexual functioning questionnaire, and with the help of CSFQ, we can assess sexual function. We asked women about pleasure, desire, arousal, and orgasm, and after adding individual items, we can get total score and subscale scores. And the most important thing for you, that below cut-off points, we can say about decrease in sexual function. So what are the results? Women with POP had the lowest scores in each category. Women with PFD had 2 out of 6 categories above the cut-off points scores. And as you may notice, other women achieved much better results. What about treatment? Unfortunately, a huge number of women with diagnosed POP are not treated by a specialist. And what is more, at stage 1 and 2, we can use non-surgical treatment. Do women use a help of urophysiotherapist? Our results say not exactly, because only 38% of women with PFD have visited a urophysiotherapist. And to sum up, the most significant risk factor associated with POP and also PFD is the amount of natural childbirth. Pelvic floor dysfunction can strongly reduce sexual satisfaction. women are not diagnosed by a specialist and they don't receive adequate treatment. To our surprise, there is no correlation between BMI and PFD. And the last one, women with PFD are mostly physically active. Thank you so much for hearing me out. And now it's time for your questions.
Congratulations of the study committee.
I would like to congratulate on this topic, which is personally my favorite. Usually,
nice to hear.
To the point, I think the results are very much affected by the age of the participants. There is only around 2% women in older age. And as you know, one of the strongest factors for POP is age. And I think I wouldn't be so much surprised that women are physically active if you have group that is mostly in her 20s or 30s or 40s. So moving forward, I think if you consider any publication, you would have to sort of balance the group a little bit more. It could be a little bit more challenging regarding access to social media. But looking at my mother-in-law, she's more scrolling than my son, I think. So, and she's over 70. So these are the points to be considered. Generally, a very nice study and important topic as the previous ones.
Thank you so much.
And I would like to ask about the result. Are the result compared to the other result of the study?
Okay, so I must admit that our results seem to be so reliable according to medical knowledge. And based on public health statistic, we consider that PFD and also POP are frequent disorders among women. We can say also that we found information about that vaginal delivery and also intensive type of sport can be a huge risk factor for urinary incontinence as well as other symptoms. I think we showed that. One exception was BMI because our study group BMI is correct, below 24.9 BMI. And as we know also, high BMI index is a huge risk factor for problem with pelvic floor muscles. And something about sexual satisfaction. There is no excellent numbers of publics of articles about POP and correlation between POP and sexual satisfaction. We found only one article on PubMed about using CSFQ in POP group. So according to medical knowledge, we know that PFD can strongly reduce sexual satisfaction, and the results show that too.
Need to interrupt. Thank you for your answer. Okay, and yes, maybe we need to back. Yes, number 10, Łukasz Karoń. Are you here with us online or I don't see him? Okay. So all the submitted papers have been presented. We congratulate all of the presenting authors and participants of the gynecology and obstetrics session. At this point, I would like to ask the president of the jury for a few words. Maybe I go. See you. Few words to sum up the session. Thank you.
To ja może już zmienię na polski z pewnego rodzaju ulgą. Ja bardzo chciałam wszystkim podziękować, bo zdaję sobie sprawę, ile to jest Państwa pracy i to nie zamyka się najczęściej w ciągu jednego tygodnia, tylko trwa zdecydowanie dłużej i zarówno ja, jak i pan doktor Wikarek i pani magister Motyk doceniamy Państwa zaangażowanie i chęć rozwijania ginekologii i położnictwa, co ja zawsze bardzo, bardzo mnie to cieszy, dlatego że to jest taka gałąź, która często jest pomijana, bo jest dużo prac z kardiologii, z interny i różnych innych. Także to są wszystko bardzo cenne prace i ja zachęcam Państwa, żeby te tematy rozwijać, biorąc pod uwagę zarówno i nasze komentarze i komentarze też opiekunów. No i mam nadzieję, że spotkamy się za rok w tym gronie lub nawet jeszcze większym. I życzę miłego popołudnia i miłego weekendu w takim razie.
We have a message from our committee online, Dr. Kuba Staniczek. A great session, good work, congratulations from Doctor. Yes, and thank you for those words, and thank you for all our committee. Now we would like to cordially invite you for the decoration and closing ceremony of the SIMC 2024 conference, which will be held in Theatre Rialto today on the 7th of May at 6 p.m. And once again, huge congratulations for all of you, and see you next year during SIMC 2025. Thank you very much.